Welcome to the Surgical Educator's Advanced Online Surgery Masterclass. In this episode, we will be discussing elaborately about two cases of small bowel obstruction, one in an adult female with post-op adhesive obstruction and another with a pediatric obstructed inguinal hernia. Allow the words in the podcast to permeate into your mind. Visualize the patient or patients discussed in your mind's eye, or run a mental movie of the patients to have an indelible impression. By doing so, you will experience an immersive and transformational learning experience. This will eventually result in achieving excellence in surgery. So I want you to imagine your digestive tract as, well, basically a continuous, highly coordinated, 20-foot-long highway.
Yeah, a very busy, very active highway.
Right. Now imagine that highway is just suddenly completely barricaded. The traffic of food, the fluid, the gastric juices, it all just keeps coming.
It has absolutely nowhere to go.
Exactly. The pressure rapidly builds, and the clock immediately starts ticking toward, a pretty catastrophic biological rupture.
Yeah.
So today's deep dive into the source material is about exactly that. We are tackling one of the most classic, yet undeniably terrifying presentations you'll ever face.
Oh, absolutely. The acute abdomen.
Right. Specifically, small bowel obstruction, or SBO. You are going to be the detective here, figuring out what went wrong, mapping the damage, and ultimately deciding if you need to cut.
And it's a foundational topic for a reason, you know? To really master this, you can't just memorize a symptom list. You need to understand fluid dynamics, pressure, and just have the confidence to take decisive action.
Because the stakes are huge, right?
Monumental. I mean, intervening at the right moment versus waiting just a few hours too long, it can quite literally be the difference between a routine recovery and a fatal bowel necrosis where the tissue just dies inside the patient.
I am so ready for this. The physiological mechanics are going to absolutely blow your mind. Let's bring up slide 1. You'll see the title here. Small Bowel Obstruction, the Acute Abdomen by Professor Dr. Selvaraj.
This is our roadmap.
Yeah, we're looking at two really realistic simulated cases today. One adult, one pediatric. We'll compare them and pull out the fundamental surgical principles you absolutely need to know.
And we are looking at everything through the lens of physiological mechanisms. You have to understand the why behind the clinical decision. If you grasp the actual physics of the gut, the protocols just make logical sense.
The physics of the GI tract. I love that framing. It's hydraulics and pressure, which sets us up perfectly. Let's bring up slide 2, where we hit the ground running with the diagnostic quartet.
4 hallmark symptoms.
Okay, let's unpack this. Going back to that highway analogy, the obstruction is the massive roadblock. That creates 4 distinct warning sirens.
Right. And every single one of those, colicky, abdominal pain, bilious, vomiting, distension, and obstipation, they're just the direct mechanical result of that roadblock. Let's look at the first one on the slide. Colicky abdominal pain.
It says it lasts 3 to 5 minutes per episode.
Yeah, and crucially, the patient is relatively comfortable between the attacks. It's not a constant burning pain.
Which immediately makes me wonder, if your bowel is physically blocked, why is the pain coming in waves? Shouldn't a physical block just hurt constantly?
You'd intuitively think so, but it comes down to peristalsis and smooth muscle. The bowel is a long muscular tube. When a block happens, the enteric nervous system, the brain of the gut, senses that massive stretch from the backup.
And it panics.
And basically, it responds by working harder. The bowel muscle violently spasms, clamping down with immense force to try and, push the contents past the block.
So the gut is essentially trying to punch its way through a brick wall.
That's a great way to picture it. And that hyperactive muscle contraction causes ischemic pain. It squeezes its own microscopic blood vessels shut, starving itself of oxygen for a moment. That intense cramp is the colic.
Oh, wow.
But smooth muscle can't maintain that contraction forever. After a few minutes, it literally exhausts itself. It runs out of ATP.
So it stops.
It stops, it rests, the pain subsides, and the patient might actually feel okay for a minute. But as the pressure builds again, it fires again, and the cycle repeats.
It's like an engine revving into the red line, stalling out, and then trying again. Incredible.
Yeah.
Okay, second part of the quartet. Bilious vomiting. Greenish fluid. The slide says it's more profuse in a proximal obstruction.
Right. The location of the roadblock dictates the vomiting. If it's proximal high up in the small bowel, the available reservoir space is tiny. You only have a few feet of tubing before you hit the stomach.
So the traffic backs up into the stomach almost instantly.
Exactly. The stomach stretches, triggers the emetic center in the brain, and they vomit early and profusely. And because it's below where the bile enters the duodenum, that fluid is mixed with green bile.
Makes total sense. Small reservoir, early overflow. But what if the roadblock is lower down, like near the end of the small bowel?
Distal obstructions change the dynamics. Now you have up to 20 feet of small bowel acting as a massive reservoir. The fluid, the secretions, the swallowed air, it pools and expands for hours or days.
But they still vomit eventually, right?
They do, but it takes much longer. And here's where it gets pretty unpleasant. Because that fluid is stagnant for so long, the normal bacteria overgrow and ferment. By the time it backs up to the stomach, it might become feculent.
Wait, feculent, you mean?
Yes, smelling and looking like feces. It's not formed stool from the colon, but it's heavily degraded, stagnant small bowel fluid that has effectively become fecalized.
That is absolutely horrifying, which leads perfectly into the third symptom, abdominal distension. The physical backup. The slide highlights central distension and visible peristalsis.
All that fluid and gas has to go somewhere. It forcefully dilates the bowel loops. It's central because the small bowel is in the center of the abdomen. In a thin patient, you can actually see the waves of peristalsis rolling across the skin.
Like a snake moving under a blanket. I've heard that description.
It's very accurate and very ominous.
And finally, the fourth siren. The proof that the highway is 100% shut down. Obstipation. Absolute constipation. No flatus, no stool at all.
Right. Obstipation is the definitive sign of a complete mechanical block. We have to differentiate it from severe constipation. If they pass even a tiny amount of gas, it might just be a partial obstruction.
Some traffic is squeezing by.
Exactly. But absolute obstipation means the roadblock is total. The bowel distal to the block has completely emptied itself, and now the pipes are totally dry.
Okay, so we have our quartet: colic, vomiting, distension, obstipation. Transitioning conceptually from these abstract symptoms to a real human being. Let's bring up slide 3. We're meeting our first patient, Mrs. Mira, 55-year-old female.
Let's look at her vitals.
Right. Her heart rate is 105 beats per minute, so she's tachycardic. Blood pressure is 140/90, and a mild temp of 37.2 Celsius.
And looking at her symptom tracker on the slide, it's the exact textbook quartet: 24-hour history of colicky pain, bilious vomiting ×2, and absolute obstipation for 36 hours.
But here's where it gets really interesting. Her surgical history. 2 previous C-sections and 1 hysterectomy. All open laparotomies. Why is this a blaring neon sign for a surgeon?
Because it explains the physiological mechanism of her crisis. Every time a surgeon opens the peritoneal cavity, the sac holding your organs trauma occurs to that delicate lining, the peritoneum.
Right, and the body senses the injury and sends in the repair crew.
Exactly. The body lays down a temporary scaffolding of fibrin to bridge the gap. Normally, once healed, a process called the fibrinolytic cascade kicks in. An enzyme called plasmin acts like biological scissors to dissolve that scaffolding.
But I'm guessing that process can break down.
Often, especially after multiple open surgeries like Mrs. Mira. The blood flow to the traumatized tissue is impaired, the biological fissures fail, and the fibrin deposits become permanent, dense bands of collagen.
Adhesions.
Adhesions.
I visualize it as like internal scar tissue acting like crazy glue, or maybe tight rubber bands stretching across the cavity, tethering things together.
Perfect analogy. And you can have these crisscrossing your abdomen for decades with no issues. The bowel just slides around them. But one day, entirely randomly, a loop of bowel slips under a band, or the band acts like a fulcrum and kinks the bowel exactly like kinking a garden hose.
Instantly pinched shut. That is terrifyingly arbitrary. Decades later, a C-section scar just kinks the hose.
So looking at her exam on the slide, she has a distended tympanitic abdomen.
Tympanitic meaning it sounds like a drum when tapped because it's full of gas.
Right. But I want to zero in on this one detail: hyperactive bowel sounds, described as high-pitched tinkles. What does that actually sound like, and what's the physics there? It's an eerie, specific sound. Through a stethoscope, it literally sounds like water slowly dripping into a tin cup. A metallic tinkling.
Wow.
To understand the physics, think about an acoustic guitar string. When you pull it incredibly tight, the pitch goes up. The obstructed bowel works the exact same way. The fluid and gas intensely dilate the wall, stretching the smooth muscle totally taut.
So the bowel becomes a tightened string.
Yes, a highly pressurized acoustic chamber. When a drop of fluid falls or a bubble squeezes through, the resonance produces that high-pitched metallic tinkle. It's the audible sound of immense physical pressure.
That's brilliant. Her exam also notes generalized tenderness but no guarding, so her muscles aren't locking up, and she's dehydrated. We need a picture to prove our theory, though. Let's bring up slide 4. Abdominal X-ray.
The crucial question on the slide: what's the most common cause in adults, and the first-line imaging?
The slide says postoperative adhesions, 60 to 70%.
Yes. In surgery, there's an unwritten rule. If an adult presents with obstruction symptoms and has a surgical scar anywhere on their belly, adhesions are guilty until proven otherwise.
And the first-line imaging is a plain abdominal X-ray in 2 views, supine and erect.
Right, lying flat and standing up.
Okay, looking at the X-ray on this slide, to me it's just cloudy gray blobs, but there are 3 red flags highlighted. First, dilated loops greater than 3 centimeters.
That's the 3-centimeter rule. Normal small bowel rarely exceeds that. When it dilates beyond 3 centimeters, it's objective proof of a mechanical backup. The supine view is best for measuring this.
Next, it points out stepladder air fluid levels. What are we physically seeing here?
This is why the erect view is critical. When the patient stands up, gravity takes over. The heavy fluid pools at the bottom of the loop, the lighter gas rises to the top. Because the small bowel zigzags back and forth, you see distinct, straight, horizontal white lines where fluid meets gas.
And they look like rungs on a stepladder climbing the abdomen.
Exactly. Finding multiple air fluid levels is the classic radiographic signature of an SBO.
The final piece of evidence is what's missing: a total lack of colonic gas.
The smoking gun for a complete obstruction, absolutely no swallowed air or fermentation gas is making it past the block into the colon. The colon edges on the X-ray are totally collapsed.
Okay, definitive diagnosis: complete adhesive small bowel obstruction. The highway is barricaded. Now, the instinct is to cut her open and untangle it, but surgery caused this in the first place.
Right. Which brings us to the decision-making protocol.
Let's bring up slide 5. Conservative management versus indications for surgery, because not every obstruction needs a scalpel.
This is the nuance. Many adhesive SBOs are actually partial, or the band just needs the bowel to deeply decompress so it has slack to untwist itself. So unless they're crashing, we start with a protocol surgeons call drip and suck.
Drip and suck. Gotta love medical slang. Let's break down the 3 pillars on the slide. First, NPO, bowel rest, nil porose.
Simple logic. Don't add traffic to a blocked highway. We stop all oral intake to prevent adding physical volume and to stop stimulating peristalsis. We want the muscle to rest.
Second, NG tube decompression, the suck. You pass a long tube down the nose into the stomach and hook it to suction. Honestly, that sounds barbaric for someone already in pain. Is it that strictly necessary?
It is notoriously uncomfortable, yes, but it is an absolute necessary evil for 2 reasons. First, it physically empties the stomach of all that backed up fluid and air.
Relieving the pressure.
Instantly. It reduces distension and provides immense pain relief. Second, and more importantly, it protects their life. These patients are vomiting profusely. If they vomit while lying down, they are at an incredibly high risk of aspirating.
Inhaling feculent vomit into the lungs.
Exactly, which causes a lethal rapid aspiration pneumonia. The NG2 keeps the stomach totally empty, virtually eliminating that risk.
Okay, the discomfort saves their lungs. I accept that. Now, the third pillar, the drip. 4V fluids. Why is hydration such a focal issue? Her heart rate was 105, compensating for dehydration, but she's not sweating. Where is the fluid going?
This is a crucial physiological concept called third spacing. We have to look at Starling's forces at the capillary level.
Starling's forces. Okay. Unpack that.
When the bowel obstructs, it dilates massively. The pressure inside the lumen increases drastically. Now, the blood vessels run through the wall of the bowel. This massive internal pressure physically compresses the thin-walled veins, trying to drain blood away.
The arterial blood pumps in, but the venous blood can't get out.
Right, a microscopic traffic jam. As the veins get congested, the hydrostatic pressure, the physical pushing force inside the tiny capillaries, shoots way up. According to Starling's forces, this pushes massive amounts of plasma water out through the capillary walls.
Oh, wow. So it's squeezed out of the bloodstream.
And it floods into the interstitial tissue of the bowel wall, causing it to swell, and eventually weeps directly into the bowel lumen itself.
So the fluid is technically still inside her body, but it's trapped in the pressurized pipe, where it's totally useless to her cardiovascular system.
Exactly. It's third spaced. A patient can literally hide several liters of fluid inside their obstructed bowel. Their blood volume drops, blood pressure drops, heart rate spikes, like Mrs. Mira's 105 and kidney shutdown.
So aggressive 5E fluid resuscitation is required to literally save their circulatory system while the bowel rests.
You're replacing the hidden fluid, exactly.
Brilliant. Okay, so we've instituted drip and suck. The slide says clinical improvement within 48 to 72 hours leads to resolution for partial obstructions. Let me push back here. 72 hours. With a tube down my nose. Why does it take so long?
It's the most anxiety-inducing waiting period in surgery. But the biological process of edema reabsorbing and spasms relaxing is just slow. During that time, though, you watch them like a hawk. Serial exams every few hours.
Looking for improvement.
Right. If pain improves, NG output drops, and they triumphantly pass flatus, the highway is open.
But the flip side is true, too. We must be ready to pivot to the right side of slide 5. Indications for surgery.
Your finger is always hovering over the panic button. The absolute indications are, first, simple failure of conservative management after 72 hours. Second, and much more urgently, signs of strangulation.
The slide lists fever, tachycardia, peritoneal signs, and leukocytosis, which is high white blood cells. Strangulation sounds like a dramatic shift. What's biologically happening?
Strangulation means the extreme pressure has finally choked off the arterial blood supply entirely. The bowel tissue isn't just congested anymore, it's actively dying. It's ischemic.
And if you wait,
That dead tissue loses structural integrity, perforates, and spills highly toxic feces directly into the pristine abdominal cavity, overwhelming peritonitis, septic shock, massive mortality rate.
so how do you pinpoint the exact moment it turns to strangulation?
Systemic alarms. If her mild tachycardia suddenly jumps to 134, a fever spikes. White count doubles. Or, crucially, her pain changes from colicky waves to constant, severe, unrelenting, localized pain with muscle guarding.
Guarding meaning her abs rigidly lock up when you press on her belly.
Yes, a peritoneal sign. If you see those, you abandon the drip and suck instantly. You do not wait another minute. You go to the OR.
The slide also lists closed-loop obstruction, but I want to hold on that. We'll dive deep into that terrifying trap later. For now, let's totally shift gears. We're leaving the adult ward and heading to pediatrics, where the rules completely change. Let's pull up slide 6.
Pediatric presentation requires a completely different mindset. The physics are the same, but the etiology, the root cause, is drastically different.
Let's meet baby Arav, 2-year-old boy. Symptom tracker shows inconsolable crying for 8 hours, bilious vomiting ×2, no stool today. Vitals show a heart rate of 130, significantly tachycardic, and a slight temp of 37.5 Celsius.
You have to translate pediatric symptoms. The crying is his version of colicky pain. The bilious vomiting confirms the block below the bile duct, but the physical exam is the snark divergence.
Right, distended abdomen. But the key finding is a firm, tender, irreducible swelling in the right groin extending to the scrotum. No overlying red skin, no guarding.
There are no previous surgery scars here. If it isn't adhesions, what is causing the obstruction in a 2-year-old? It's almost always a congenital issue, an anatomical defect they were born with.
So in this case, an obstructed inguinal hernia.
Exactly. To understand why, we need quick fetal embryology. A male baby's testicles develop high up in the abdomen. As the fetus grows, they descend through the abdominal wall into the scrotum, pulling a little pocket of the peritoneal lining with them,
A tunnel?
called the processus vaginalis. Normally, before birth, it seals off completely. But if it fails to close, it leaves a padded, wide-open tunnel from the abdomen to the scrotum.
And a loop of his small bowel has just slid down that tunnel and gotten stuck.
Yes, the bowel herniated. The entrance is a tight, fibrous ring. The bowel got pinched at the neck, trapping it, and creating the same catastrophic backup we saw in Mrs. Mera.
This brings us to a massive physiological distinction on slide 7. Obstructed hernia versus strangulated hernia. Two very different images. Let's break down the left side first. The obstructed hernia.
In a purely obstructed hernia, the traffic is stopped, you see the vomiting and distension, but, and this is vital, the blood supply is still intact. Arteries pump in, veins drain out, the tissue is alive, no systemic toxicity.
The slide says initial management is gentle, manual reduction under analgesia or sedation, often in the Trendelenburg position. Explain the mechanics.
Because the bowel is healthy, you have a window. You give potent pain medicine or sedation to relax them and stop the crying, which increases intra-abdominal pressure. Then, Trendelenburg position, tilting the bed so the head is lower than the pelvis.
Using gravity to pull the bowel back.
Right. Gravity pulls the loops back, and the physician applies gentle, steady pressure to the groin swelling, massaging the trapped bowel back up through the ring. If successful, you hear a gurgle, swelling disappears, emergency cured.
Then he goes home.
You bought time, the defect is still there, you discharge them, let swelling go down, and schedule definitive surgery later under calm, controlled conditions.
But looking at the right side of slide 7, the strangulated hernia, the tissue looks darker, angrier. How does a hernia progress to strangulation?
It's a predictable ischemic cascade. It starts with swelling. As the trapped bowel dilates within that tight, fibrous ring, pressure increases. The blood vessels run through that ring.
Like a tourniquet on an expanding balloon.
Precisely. First, the low-pressure lymphatic vessels squeeze shut. Swelling worsens exponentially. Next, the low-pressure veins are choked off. Arterial blood pumps in but can't get out. The bowel wall becomes massively engorged with stagnant blood.
And the ultimate point of failure.
Tissue pressure inside the swollen bowel exceeds arterial pumping pressure. Arterial inflow stops completely. Ischemia sets in. Cells die, tight junctions break down, bacteria translocate, and you develop rapid systemic toxicity.
Hence the fever, extreme tachycardia, and red, incredibly tender skin over the groin. And the slide has this massive warning. Surgical emergency, no manual reduction. Why is pushing it back so strictly forbidden?
Think about the biology. That bowel is gangrenous, dead, heavily laden with bacteria, thin as wet tissue paper. If you force that friable loop back through a tight ring, two disasters happen. One, it might literally pop and rupture in your hands.
That's total disaster.
Two, even if it doesn't pop, you've just pushed a necrotic infected organ back into the pristine peritoneal cavity. You've hidden a ticking bomb and created massive intra-abdominal sepsis.
Taking a localized problem and making it a systemic catastrophe. So if there's any sign of strangulation, you go straight to the OR.
Straight to the OR. Open the groin. Deal with it under direct vision.
Advancing to slide 8. Let's play this out. The hernia won't reduce, or we suspect strangulation. The emergency procedure is an inguinal herniotomy. Let's walk through the OR steps on the slide.
Step 1. Open inguinal incision directly over the groin crease. Step 2, the most critical moment, identify the sac, open it, and meticulously inspect bowel viability before doing absolutely anything else.
Right, because once you cut the tight ring, the pressure releases, and the bowel might slide up into the abdomen on its own. You have to grab it and look at it first.
You never let it escape your grasp until you confirm beyond a shadow of a doubt it's pink and viable. If dead bowel slips back, you have to cut the child's entire belly open to find it.
Step 3 is high ligation of the sac. And there's a huge note here. No mesh in children. Why do we explicitly avoid mesh in pediatrics when adults almost always get it?
It comes back to the root cause. Adult hernias are acquired from years of wear and tear, lifting, chronic coughing. The tissue is failing, so it needs a synthetic mesh patch for structural integrity.
But a 2-year-old's tissue isn't degraded.
It's perfectly robust. A pediatric hernia is congenital, just a tube that failed to close. All you do is separate the sac from the blood vessels, tie it off high up with a suture, and cut it. The health muscles act normally.
Plus, if you put rigid plastic in a toddler.
Right. As the child's body grows exponentially, a non-expanding mesh causes massive anatomical complications and chronic pain. Fix the defect, let healthy tissue do the rest.
Makes perfect sense. And step 4 is plan for elective contralateral exploration, checking the other side eventually. Now, let's shift back to the adult world. Let's look at slide 9. Here's where it gets really interesting. The suspected SBO algorithm, specifically the gastrographin challenge.
A brilliant diagnostic and therapeutic tool. Remember that agonizing 72-hour waiting period for Mrs. Mira? Gastrographin helps us predict the future much earlier. We give them this heavy, radiopaque contrast liquid.
And we track it. Let's trace the flow chart. Down the left side. If you give it, take an x-ray 4 to 6 hours later and see the contrast has reached the colon, you have your answer.
It definitively proves the obstruction is only partial. Fluid is getting passed. These patients will almost always resolve natively without surgery. You can confidently continue observation.
But gastrographin actively helps clear the obstruction too, right?
Yeah.
How?
It's the physics of osmolarity. Gastrographin is highly hyperosmolar, incredibly dense with solutes. When it hits the swollen edematous bowel wall near the adhesion, osmosis takes over. It violently draws water out of the swollen cells into the bowel lumen.
Like pouring salt on a slug, shrinking the tissue from the inside out.
Exactly. Shrinking the wall physically widens the kinked passageway. Simultaneously, all that water acts as a heavy fluid wedge, a cathartic flush that often untwists the kink and forces the bowel open.
That's biological engineering at its finest. But the right side of the flow chart.
Yeah.
What if no contrast reaches the colon after 6 hours and the patient deteriorates?
Then it's proven the block is absolute and complete. Delaying further increases the ischemia risk. You go straight to surgery.
And there's a vital caveat on the slide in bright orange.
Where?
Strangulation, immediate surgery, bypass contrast challenge.
Absolutely. Gastrographin takes 4 to 6 hours. If the patient has a high fever, rigid abdomen, or severe localized pain, you do not have 6 hours to wait. The bowel is actively dying. You bypass all algorithms and go straight to the OR.
Transitioning to slide 10, let's consolidate. Adult versus pediatric SBO comparison. Let's do a rapid-fire summary.
Etiology. Mrs. Mira is post-op adhesions. Baby Ara is a congenital patent processus vaginalis.
Risk factors. Mrs. Mira had multiple prior open surgeries. Baby Arav is male, with prematurity increasing the chance the tunnel doesn't close.
Initial management. Adult is drip and suck NPO, NG tube, IV fluids. Child, if no toxicity, is immediate, gentle, manual reduction under sedation.
And the surgical fix. Adhesiolysis for the adult, physically cutting the scar band, herniotomy for the child, tying off the sac with no mesh.
Okay, part 4, moving to slide 11. Clinical pearls, traps, and the OR.
These are the light bulb moments for a great surgeon.
We covered the X-ray signature, but the second pearl is fascinating, the virgin abdomen.
If an adult presents with textbook SBO symptoms but has a virgin abdomen, zero history of surgery, no scars, you must radically change your algorithm.
Because adhesions shouldn't be there. Precisely. They're exceedingly rare without surgery. You must assume something insidious is causing the block. Meticulously examine every hernia orifice looking for trapped bowel.
And if you find nothing,
your index of suspicion for an undiagnosed malignancy, small bowel lymphoma, neuroendocrine tumor, advanced colon cancer skyrockets. It mandates an immediate contrasted CT scan to find the hidden mass.
the fourth pearl is the danger sign. Peritoneal signs mean strangulation. Go straight to the OR. Let's bring up slide 12. Warning signs and traps. What are the biggest mistakes a doctor can make?
First trap, the misdiagnosis trap. Happens all the time in the elderly or very young. Patient comes in vomiting with crampy pain, and the ER writes it off as a tummy bug or gastroenteritis. They go home, and their bowel strangulates and perforates in their living room. You must aggressively prove it's not an SBO first.
Second trap is delaying the inevitable. Waiting on conservative management when strangulation signs are present. Third trap, forceful reductions in pediatrics causing bowel rupture. But I want to deep dive into this fourth trap. Missing closed loops. The slide says it leads to rapid, fatal ischemia. What is the architecture of a closed loop?
It's the most dangerous mechanical variation. In a normal SBO, you have one roadblock. The pressure can back up into the stomach and be vented by vomiting or the NG tube, a built-in pressure relief valve.
Right.
In a closed loop, the bowel is obstructed at 2 distinct points simultaneously. Imagine a rogue adhesion band trapping a loop, acting like a noose around both the entrance and exit. Or a volvulus, where the bowel twists completely around on itself.
Sealing itself off at the base, like tying off a balloon at both ends.
Exactly. A sealed biological balloon. The cells lining that trapped segment don't know they're trapped. They keep secreting fluid, the bacteria keep fermenting gas, but it's hermetically sealed.
The relief valve is gone. The pressure must build incredibly fast.
Exponentially fast. Applying the place's law wall tension increases as radius increases. The immense pressure rapidly crushes the venous drainage and quickly after collapses the arterial supply of that specific loop. It will become gangrenous and perforate in a matter of a few short hours.
How do you catch it?
The glaring warning sign is pain completely out of proportion to the physical exam. They might be screaming in agony, but their belly isn't massively distended yet. If you suspect a closed loop, you cancel the 48-hour waiting period and operate immediately.
Terrifying. Which sets the scene perfectly for slide 13. Viable versus non-viable bowel in the OR. You're the surgeon, patient is open, you've cut the adhesion, you're holding a bruised segment of bowel. Do you keep it or resect it?
It's one of the most consequential decisions in surgery. Leave dead bowel in, it perforates and kills them.
You can't just cut out anything slightly bruised.
Right. Resecting too much healthy bowels subjects them to a dangerous anastomosis, sewing the ends together, which can leak, or leaves them with short bowel syndrome, needing IV nutrition for life.
So how do you know if it's alive? Let's look at viable bowel.
You're looking for dynamic cellular life. Firm, resilient musculature, a shiny serosal surface reflecting the OR lights. And you check the mesentery, the fat supplying the vessels, for tiny, pulsating mesenteric arteries.
The slide notes it pinks up upon release.
When first released, it might look dusky or blue from trapped venous blood. Wrap it in warm, wet sponges, wait 5 to 10 minutes, and watch. As oxygenated arterial blood rushes in, the tissue should literally transition from purple back to a vibrant light pink.
Like a pale person flushing with color. And the final test.
Flick the bowel wall with your finger. You should see a wave of peristalsis ripple away. That proves the neuromuscular architecture is alive.
But the other side of the slide. Non-viable or gangrenous bowel. The image is dark, almost black.
It's completely dead. The surface is dull and lusterless. The muscle is flabby and friable, meaning it'll tear or crumble if you try to sew it. No peristalsis, no microscopic pulses because the vessels are clotted off.
And the color test.
It doesn't pink up. It remains persistently black or gray. If it's gangrenous, there's no debate. You resect that entire dead segment back to healthy bleeding margins.
Okay, home stretch. Looking at slide 14, the 6-point summary, let's rapidly run through these rules.
Rule 1, the quartet. Colicky pain, bilious vomiting, distension, obstipation. Rule 2, adhesions dominate in adults, 60 to 70%. Look for the scar.
Rule 3, decompress early. Drip and suck resolves 70 to 80% of partial cases medically. Rule 4, strangulation is an emergency. Fever, tachycardia, guarding mean emergency laparotomy.
Rule 5, pediatric caveat. Irreducible hernias are top cause in kids. Attempt gentle manual reduction under sedation first if no toxicity.
Rule 6, recurrence risk. A patient who resolves medically has up to a 50% recurrence rate in their lifetime. Patient education on symptoms is non-negotiable. Now for the grand finale. Let's bring up slide 15, the masterclass detailed infographic. This is the ultimate cheat sheet. Let's touch on a few advanced nuances here. First, pathological taxonomy, differentiating mechanical ileus from paralytic or adynamic ileus, the silent bowel.
In a paralytic ileus, there is no physical blockage. The smooth muscle has simply stopped working. It's paralyzed. Very common after major abdominal surgery or from severe metabolic derangements like hypokalemia, low blood potassium.
So the presentation looks similar.
Distension and vomiting, yes. But because the muscle isn't fighting a block, there is absolutely no colicky pain. And with the stethoscope, bowel sounds are dead silent. You never operate on a paralytic bowel.
Moving to diagnostic imaging and labs, it introduces the contrasted CT scan as the gold standard for finding the transition point.
Plain X-rays are the cheap first step, but a contrast CT provides a 3D roadmap. You follow the dilated loop until it abruptly collapses to normal caliber. That transition point is exactly where the adhesion or tumor is. Plus, 5 trash shows if the bowel wall is enhancing with blood flow, helping spot early strangulation.
Labs mentions low sodium and chloride from profuse vomiting.
The stomach is a reservoir of hydrochloric acid. Vomiting ejects massive amounts of hydrogen and chloride ions, leading to hypochloremic, hypokalemic metabolic alkalosis. Their blood becomes dangerously alkaline. You must aggressively correct this.
Finally, surgical principles, the 3 R's. Release, resect, reconstruct.
Release the adhesion or hernia, resect any gangrenous bowel, then reconstruct.
And reconstruction depends on stability.
Entirely. If they're stable and tissue is healthy, you do a primary anastomosis, sew it back together. If they're in septic shock or tissue is swollen and friable, an anastomosis will fail and kill them. You divert the bowel ends through the skin as a temporary stoma, let them recover for months, and reconnect later.
Okay, so bringing it all together, what does this truly mean? It really highlights the incredibly delicate, complex engineering of the GI tract.
It's an exquisitely balanced system of neurology and hydraulic fluid dynamics.
And yet, a single microscopic inflammatory response to a scalpel cut years ago can lay down a tiny invisible band of scar tissue. That scar waits silently for decades. Then, the bowel geometry shifts a millimeter, it kinks around that scar, and instantly triggers a massive lethal cascade requiring emergency surgery.
It's a powerful reminder that our past medical history, our traumas, are permanently etched into our internal anatomy, silently shaping our future risk.
That is an incredibly sobering perspective to end on. The body truly keeps the score. And finally, slide 16. Kindly like, subscribe, and share this video in your social media and press the bell button to get notified regarding my latest uploads. Wish you all a great learning experience. Thank you.